My name is William Dillon. I'm joined by our president and co-founder, Bhavya Rahani, Dr. Rahani, and we're absolutely delighted to have two esteemed members of the South African community of scientists discuss their experience with the Omicron variant and some of the future aspects to controlling this pandemic. So we're joined this morning by Dr. Wasila Jazza, who's a physician and a public health medicine specialist. She works at the National Institute for Communicable Diseases, where she leads a group in hospital surveillance for COVID-19, and she's currently registered towards a PhD as well, busy woman at the University of Western Cape, and she'll lead us off this morning on summarizing what South Africa has recently gone through and is still going through with regard to Omicron. And then following her lecture, we'll have a Q&A that Dr. Rahani will lead with Dr. Lucille Blumberg. She is currently a consultant at Right to Care, which is an organization devoted to the care and treatment for services for various infectious diseases in South Africa. Until last September, she was the deputy director at the National Institutes for Communicable Diseases of the National Health Laboratory Service in South Africa, and a founding head of the Division of Public Health Surveillance and Response, and a world expert and recognized expert in infectious diseases. I could go on, but I think it would be more interesting for the group to hear from them directly. We'd like to thank them both in advance for making the time. It's late in South Africa, and we're delighted to have you. So, Dr. Jazza, if you would like, you may start and share your slides. Thank you so much in advance.
Hello, colleagues around the world, and thank you so much to Health for the World for inviting us to share a little bit with you today. Prof. Lucille and I will share a bit of our experience of the Omicron wave in South Africa. So to date, we've had kind of well over 3 million cases diagnosed and over almost 95,000 deaths reported in South Africa. Those are reported COVID-19 deaths. We've had 4 waves of COVID-19 pandemic, each one dominated by a different variant. The first, the ancestral lineage. The second wave dominated by Beta. The third wave dominated by Delta. And this fourth wave, of course, dominated by Omicron. And just by way of context, before I share with you some of our data from the fourth wave, a seroprevalence community study done just before the fourth wave showed a seroprevalence of about 73%. And vaccination coverage just before the fourth wave in November was 40% of adults population had received at least 1 dose. And also just to share with you that during the previous 3 waves, we've had various levels of national restrictions, but during the entire wave 4, we've had no increase, and so just the very lowest level of restrictions during wave 4. And we've also had a move in South Africa to reduce our isolation period to 7 days and to remove the quarantine period and contact tracing. So that just shows you, it's very busy, but if you look at the top, it shows you the levels of alert that we've had in each of our waves. And you can see that during the peaks of our waves, we shifted up to higher levels of alert responses. But as I said before, during wave 1, government opted not to change alert levels at all, despite the emergence of this very transmissible variant. We decided to wait and look at the hospitalizations and base our restriction levels on that. Just also as context, this is the vaccination rate in South Africa. About 40 million of adults have received a vaccine dose, which is now about 46% of individuals who've gotten a dose. It varies quite a bit by province, and you can see the highest being in our Western Cape province at 54%, the lowest being in KwaZulu-Natal at 39%. And it also, vaccination also varies by age, with the lowest proportion of vaccinated are in young adults, 18 to 34, and the highest vaccinated are those over 60. Let me show you some data of our fourth wave. The fourth wave is ending. We are close to reaching the end of wave threshold in cases. And what we saw in this wave is a decoupling of cases and hospitalization and deaths. And so really there was a lower proportion of admissions in the fourth wave and deaths compared to the previous waves. Just showing that a different way. This is the fourth wave as a proportion of the third wave peak. And you can see that cases peaked at about 111% of the third wave peak, while admissions peaked at about 67% of the third wave peak, and deaths peaked at about 27% of the third wave peak. And so while there were more cases, overall there were less admissions and less deaths in the fourth wave. We know that confirmed deaths are not well reported and are underestimated. So we also monitor the excess mortality, which is all natural deaths reported to our vital statistics. And what we saw in the first, second, and third wave was huge increases in deaths. And so the 294,000 excess deaths is well above the 94,000 reported deaths that we've had. But what we saw in the fourth wave is a much lower peak in deaths, in excess deaths, and already a decrease over the last 4 weeks in excess deaths. And so a very different picture in the fourth wave compared to the first 3 waves. So we've done some analysis looking at severity in the Omicron-dominated fourth wave compared to the previous 3 waves. There's a preprint in the Lancet, which we've now updated and hopefully will soon go into publication. So we've compared the full 4 waves of the ancestral, the beta, the delta, and the Omicron waves. You can see that each wave got successively bigger in terms of cases and got successively longer. But then Omicron kind of changed their trend with a very quick, sharp increase, a quick peak, and then decrease, and a very short wave. So when we looked at measures of severity, what we found was in the fourth wave in black, there were a lower proportion of cases admitted, 8%, compared to 13, 13, and 10% in the previous waves. There was a lower proportion of patients who needed oxygen, 23%, compared to 37, 48, and 48% in the previous 3 waves, and a lower proportion of patients had severe disease, 34%, compared to 52, 63, and 63% in the previous 3 waves, and a lower proportion of patients died, 11%, compared to 22, 29, and 26% of the previous waves. And when we did a multivariate analysis of factors associated with severe disease, you can see that compared to wave 4, there was a higher risk of severe disease in wave 1 with an odds ratio of 2/2, in wave 2 an odds ratio of 3.86, and in wave 3 an adjusted odds ratio of 3.73. So a 2 to 4-fold increase in the levels of severity in the other 3 waves compared to wave 4. Now, of course, in South Africa, very early in the wave, we were reporting a lot of pediatric admissions, and I think we've seen the same in other countries. So I thought I'd share some data with you. This is a weekly incidence of SARS-CoV-2 cases in the 4 waves in South Africa by age group. So some of the interesting trends you can see is most cases happen in the 40 to 59 age group and the over 60s. And so it's mostly adults, middle-aged adults that are most affected by infection. However, in the 3rd wave, you can see that we had this peak of children, 15 to 19 and 10 to 14, particularly in the 3rd wave, a second peak. And this occurred because kids went back to school just around this time. We didn't have much school opened in our 1st and 2nd waves, but in the 3rd wave, when kids went back to school, we did see a peak in children. In the fourth wave, however, we didn't see increased incidence risk of cases in other age groups, but there was an increase in the very youngest, the 0 to 4, compared to previous waves. And when you look at that for just children, you can appreciate that in the third wave, we saw more teenagers, but in this fourth wave, we saw a slightly higher incidence of children under 5 infected in the fourth wave. But when you look at admissions, we see an even different picture. So most admissions are in adults over 20 years. We saw not very many. I mean, children make up about 5% of admissions in the previous 3 waves. But in this fourth wave, we saw increases not so much in 5 to 9 and 10 to 14 or 15 to 19, but we saw this large increase in admissions in the 0 to 4 age group. And looking at just children, you can appreciate this more. You can see teenagers and those 5 to 14 are similar to what we saw in the third wave, but children under 5 had a much higher incidence in the fourth wave compared to previous waves. So just looking at this a different way, for adults over 20, in the fourth wave, 8.2% of cases were admitted, compared to 14, and 11% in the previous wave. So a lower proportion of cases were admitted in the fourth wave in adults. But in children, 9% of cases were admitted compared to 5, 4, and 3 in the previous wave. So a higher proportion of cases were admitted to hospital in the fourth wave. And again, looking at that a different way, if you look at the proportion of cases in each age group over the total admissions, over the total admissions in that wave, you'll see that in the first, second, and third wave, most admissions were in older people over 40, but in the fourth wave in black, most admissions were in people under 40, and particularly in that under 20 age group. But despite there being a higher proportion of cases admitted in the fourth wave in children, so 9% compared to 5, 4, and 3%, all measures of severity show less severe disease even for children in the fourth wave. So the proportion who required oxygen was 12%, similar to 13% in the first wave, but much lower than the 21 and 18% in the second and third wave. The proportion who was severe was 18%, lower than the first, second, and third wave, and the proportion who died was 2%, lower than the 4, 5, and 3% in the first 3 waves. But just because we know it was the very young children who are more severely affected, I thought I'd show you the data for those under 1. And so you can see a huge proportion of cases or infections under 1 are admitted to hospital. And that's probably because we're underdiagnosing and under-testing the very young, and that most of them who are admitted to hospital actually get tested. And so, but even then, we see 15% of the under 1s needing oxygen compared to 23 and 20 in the previous 2 waves, the second and third wave. 21% were severe compared to 27, 31, and 31 in the previous waves. And 2% died compared to 7, 5, and 5 in the previous waves. And so more children seem to be admitted to hospital, but amongst those who were admitted, there was less severe disease. This is a very busy table, but this is what I want you to take from this. When you compare those under 1, 1 to 4, and 5 to 19, for each age group, you'll see that there's less severe disease in the fourth wave compared to the previous waves in every age group. But what's also evident in this table is that in terms of the measures of severity, there is more severe disease in the under 1 compared to the children who are older 1 to 19 years. And similar data is being reported from the UK and I believe from the US as well. They are seeing an increase in admissions in very young children, particularly those under 1 year, but that all reports are that these admissions are not severe disease. So just to remind you again that our children do have the lowest vaccination coverage, and also children have lower prior immunity from prior infection. In the seroprevalence study I quoted earlier, that was done in November, children under 12 had 56% seroprevalence compared to adults over 50 with 80% seroprevalence. So children, there is an immunity gap among children, which may partly explain the higher risk of admission to hospital. So just to sum up, in our fourth wave, we have seen a decline in the cases and admissions with Omicron. We've had a slower down wave compared to the very steep and rapid up wave. And in this fourth wave, we saw a different trend compared to the previous three waves, and we saw a decoupling of cases, admissions, and deaths, which means while we had many cases, there was a lower rate of hospitalization and mortality. And very importantly, health capacity was not breached in the fourth wave. We didn't have a strain on beds, on oxygen supplies, even though we had no increase in national restrictions. We know that Omicron has a growth advantage and is highly transmissible. There's a high proportion of asymptomatic infection, high secondary attack rates, and higher observed reproductive number compared to Delta. We believe that testing strategies, admission criteria, and treatment remained unchanged between waves. The only thing that changed was this new variant and some, immunity from vaccination and prior infection. So why are we seeing less severe disease and death? We're also seeing reduced risk of hospitalization reported from the UK, Canada, and Denmark. Studies are showing that patients with Omicron had lower odds of severe disease compared to Delta. So is this an intrinsic lower virulence of Omicron, or is it because of immunity from prior infection or vaccination? So some studies are starting to show, in terms of host tropism and pathogenicity, that there is a potential shift in tropism of Omicron to the upper respiratory tract compared to Delta and the wild type that had a tropism for the lower respiratory tract. And there's evidence of less severe pathogenicity in mice models and lower cleavage efficiency, which may reduce pathogenicity in terms of this entry to the cell. In terms of immunity, early data in South Africa, UK, Denmark, and Israel are showing that there's an increased risk of reinfection if you had prior infection with Omicron. There's also a reduction in neutralizing titers against Omicron in people who got their primary vaccines or had prior infection, and that vaccine effectiveness is lower against Omicron for infection and symptomatic disease compared to Delta. However, booster doses have increased vaccine effectiveness. But what is encouraging is that vaccine effectiveness against hospitalization was substantially higher than against symptomatic disease. So while you may have not been protected against getting infected, people are likely well protected against getting hospitalized and dying. And we think that might be because of good T-cell immunity, even while we lose some antibody response. In terms of Omicron in children, we saw more admissions, but less severe disease in children, and similar high rates of admission and less severe disease are being reported in the US and UK. And it seems children under 1, the youngest, had the highest admission rates and a slightly higher severity than older children. So is this again host tropism? We know that with the virus having a higher affinity or high replication in the lower airways, in the upper airways, it spared adults from developing COVID pneumonia and needing oxygen and ventilation. But in children, because of their small upper airways, they may have been more symptomatic in this wave compared to adults. And we have heard of many kids presenting with a croup presentation. And certainly from reports in South Africa, most of the admissions of children were for fever, hydration, and seizures, but not requiring oxygen and ventilation. We do know that they have a lower seroprevalence and vaccination coverage, but we also saw more incidental admissions. Children were admitted with other respiratory pathogens. Influenza A peaked at around the same time that Omicron was rising, and because we possibly are underdiagnosing the very young children. There are some limitations to our analysis. Many of you might ask, we don't often disentangle between the reason for admission and death, whether it was people with COVID or for COVID. Many admissions are in people who are just incidental positive and admitted for other reasons, but our surveillance system's not accurately able to disentangle that. It's always difficult to look at outcomes before the wave has truly ended, and you need time to accumulate outcomes. But we have reached the end of the wave, and we will update this analysis in a week or two when we've had time to accumulate outcomes for all these admissions. We didn't have vaccination and prior infection data available, which would have been useful in this analysis. And in surveillance systems, there's always some data quality and completeness issues. So I wanted to end, this part of the talk just on reflecting on a statement by the International Health Regulations Emergency Committee last week. that said that they praised South Africa for the rapid identification and transparent and rapid sharing of information on the Omicron variant of concern. The committee was concerned about the reaction of states parties in implementing blanket travel bans, which are not effective in suppressing international spread and may discourage transparent and rapid reporting of emerging variants of concern. So just to say, it was a busy time for us in the fourth wave over November and December, and we are pleased to have been able to do the surveillance work to share this with the rest of the world. And the point must be made that we were punished with travel bans that have already that cripple an already crippled economy in South Africa, and just wanted to make that advocacy point. So Prof. Lucille will probably go into some of these things a little bit more, but just looking to the future, we've had 4 waves of COVID-19, and the international thinking is shifting towards mitigating the COVID-19 pandemic. And I think we need to move away from, sort of lockdowns and, these pandemic waves where, individuals and society and economies take a huge hit. And we need to look at how we can have a pathway beyond this towards living with COVID-19. So Prof. Lucille and others wrote an op-ed in one of our media this week, and I'm just summarizing from that, and she'd probably be able to do better justice to this. But what many of us here in South Africa are advocating is that we need to end our state of emergency and disaster regulations. We need to end the lockdowns that are imposed during the waves. We need to end school restrictions and let kids get back to school, particularly because many kids get their nutrition at school as well. We need to end the frivolous sort of measures like sanitizing and thermal screening. We need to end testing at borders and testing for mild and asymptomatic cases. We need to end the quarantine period and contact tracing, and we argue for a reduction in the isolation period. We know that we will continue to wear masks for a long time to come. We need to still limit indoor events and ensure that indoor spaces are well ventilated, and particularly during wave periods need to be much more careful about physical distancing. We need to continue doing surveillance, particularly of hospitalization and death, and use those metrics for determining our national responses and levels of alert. And in the meantime, we need to maintain healthcare preparedness and get access to new treatments. New antivirals that are being used in other countries are still not available and may not be available until the end of the year in South Africa. But most important in the strategy towards moving to living with COVID-19 is vaccination. And we've got we don't have high enough vaccine coverage, but we need to target the high risk for their primary vaccine and their boosters. And many companies in South Africa are now introducing vaccine mandates. I will stop there. Thank you so much for your time, and I will hand over to Prof. Lucille, who might take us through some Q&A. And happy to share my slides and answer any questions you might have.
Oh, thank you so much. That was just marvelous. We have maybe time for a couple of questions to you, and then we'll move to the discussion with Dr. Bloomberg. One thing that I was wondering, just looking at your slides and the waves, it seemed there was a periodicity to the waves that was kind of interesting. Now we're in the 4th wave. It seems like maybe every, I don't know, 6 months or so. I couldn't actually see the number of weeks, but and I'm just wondering what your thoughts are on that. It seems like that was of concern. And the second question I had was just the reinfection with Omicron. Those of us who've been around have thought that maybe there was some immunity that was transferred by having COVID. And I think a lot of people feel like once they've had COVID, that they're free to go about their business without social distancing or masking and whatnot. And I wonder if you could just talk to that, whether the Omicron reinfection is higher with this particular variant, and why? Is there a waning of immunity? Is there no immunity? Thank you.
I think so. You're quite right that in terms of the periodicity, we have had consistently about a 3-month period between the end of the wave and the start of a new wave. We've had a winter wave, a summer wave, a winter wave, and a summer wave. Our waves, the previous 3 waves were sort of a gradual evolution from one of our 9 provinces to the next. And so the entire wave duration lasting about 2 to 3 months. However, the Omicron wave was very different. We had almost a simultaneous increase across all provinces, a simultaneous peak and then a decline. And so it's been a very tight wave. But I think you're quite right that, we seem to have about a 3-month period between waves. And really, I mean, so the emergence of a new wave is very much related to the emergence of a new variant. So each wave started when a new variant, a new transmissible variant was described in South Africa. But of course, other things that have a part to play are the relaxing of non-pharmaceutical interventions and, vaccination coverage, of course. But very much our waves have been driven by the emergence of new variants. And with regards to your second question, Omicron really broke through, any immunity from previous infection and vaccination. And so we saw very high rates of reinfection in people who had had prior infection and who had been vaccinated. But thankfully, so they did not have severe disease. So vaccines still protected against severe disease, but certainly, we know that there's waning immunity from natural infection and from vaccination. And so people shouldn't be, confident that they've had infection and that they're not at risk again.
Thank you. I'll turn it then over to Dr. Rahani and Dr. Bloomberg.
Thank you so much, Bill, and thank you, Bill, for the kind introduction. And Vasila, the presentation was excellent. Thanks for the wonderful slides and sharing your knowledge with everyone. And Professor Mohammed, who's also with us today, thanks for arranging the session, which is really helpful. Vasila, I have one question for you, and before we move on to Professor Bloomberg, we have a list of questions for Professor Bloomberg. Vasila, when you talk about the children hospitalizations, you showed the slide that you're seeing less severe manifestations in children and mostly upper respiratory tract infections. But the hospitalizations had increased. Was the hospitalization increase because of high fever? Because it doesn't seem like it was for oxygen therapy, right? What was the reason for the increased hospitalization in children?
So initially, we just saw a lot of incidental positive children. So these were not children sick with COVID, but they were admitted for other reasons, maybe for surgeries or other medical conditions, and were found incidental positive. And this just reflects the huge community spread, that it's likely that amongst those people who were in hospital, many of them were also positive, even if they may have been asymptomatic. So one of the reasons for the high admission in children was a lot of incidental positive admissions. But we also know that many kids were admitted, for reasons like I said, for fluid replacement, for fever protocols, and some for seizures. Most of the presentation in children was non-respiratory. Only 40% have respiratory presentation, and with the rest being constitutional symptoms, gastro symptoms, neurological symptoms. But very few children needed oxygen or ventilation or treatment in ICU.
All right, sounds good. Thank you so much. And now we'll move to Professor Bloomberg. Professor Bloomberg, thank you for joining us. We have some questions for you here. The first question is, can you please describe the clinical spectrum of Omicron, which you saw in South Africa?
So first of all, good morning, good afternoon, good evening, everybody, and lovely to be here. And just to pay tribute to Dr. Jassett and her team, who've really done a fantastic job in setting up and conducting the hospital surveillance program. It started from nothing, and within a few hours, we had a program up and running, and 2 years later, we have incredible information on all 4 waves. So just to recognize that. So Omicron, mostly mild, I think many asymptomatic, many minimally symptomatic, and some very similar to other waves, but lots of people describing what they call a head cold, postnasal drip, runny nose, some sore throat, adults, very little fever, extreme tiredness. And they will say, we are flattened, just like influenza for a few days, and then we're fine. So extreme tiredness. Children a lot of very high fevers, as Wasila mentioned. And so that's the commonest presentation. Cough variable, sore throat variable, but extreme tiredness, muscle pains, a feeling of just being run over by the bus. I think that's what many people have described. And then obviously the spectrum will move into more severe illness with COVID pneumonia, some ARDS, very, very similar. In fact, the same as all the other waves. But we're seeing far less of those, far less need for oxygen, shorter stays in hospital, same group at risk, perhaps slightly younger, but also those with the same comorbidities, and more unvaccinated who require admission and oxygen therapy.
All right. And as you mentioned, the severity was less. And as Vasila mentioned, there was a question about the severity that you have already answered.
So this screening of temperatures when you go into every building or airplane or whatever, I think is a very limited benefit because a lot of the patients do not have fever. And I think that's something we need to review and maybe no longer do.
Right, exactly. There's a question about vaccine. How was the vaccine effectiveness against Omicron in South Africa?
I think she covered that. Wasila, you might want to repeat that. We've certainly seen a number of breakthroughs. So those who were vaccinated with both J&J or the mRNA, which in our case is Pfizer, a number of them have become infected, but mostly with mild illness. So I don't think we'll know the true picture because many are not tested and many have very, very mild illness. But definitely previous infection, vaccination, we're seeing Omicron and we're seeing breakthroughs.
Right.
But severe illness, no. If you're vaccinated, that's the big advantage.
You know, a big question in everybody's mind is what is next, you know, after the Omicron? You know, any insights about?
I think we're all trying to be very optimistic. As Dr. Dillon mentioned, you know, we've had new variants every few months, and you know they've really catapulted the new waves. So I think we'll wait and see. I think there's lots of immunity now. Seroprevalence is very high. I think this year will really inform where we're going with COVID. So I wouldn't like to predict, but I'm cautiously optimistic that maybe we're moving in the right direction.
That sounds great. That sounds
it doesn't mean we must let go, and I think we must vaccinate all of those who are at risk for severe illness, and we must make sure our health, you know, facilities are ready. And I think very importantly, monitor hospitals for admission.
right.
So keep going. Don't let go. The end is not here yet.
I like that. You know, many of the audience today are healthcare workers, and the question is about protection of healthcare workers. You know, what kind of protection protocol was followed to protect the healthcare workers in South Africa?
Yeah, so that's a very interesting one. It's a very controversial one. I think since SARS-CoV-2 appeared, there's always been this debate about whether it is airborne or droplet spread. And I think it's probably both. I think in a confined space, especially with aerosolizing procedures, you're going to get aerosols produced and you're going to get airborne transmission. I think Omicron, I think the thoughts have been because of the high transmissibility that it's more likely to be airborne, particularly in a confined space. So healthcare workers have really borne the brunt of many infections during the waves. Many of them got infected at home or in transport, rather than looking after in the patient setting. And we've used surgical masks for our main intervention, and high efficiency particulate respirators, the N95s, for aerosol producing events. I think there's been a lot of rethinking, and I think people are moving in the direction of, perhaps there's a lot more airborne spread than not. So well-ventilated spaces, we're not paying enough attention to ventilation, doing things outside, opening windows, and not overcrowding spaces. So I think that's a key intervention.
Right. And, once a healthcare worker gets infected, what were the isolation guidelines for Omicron in South Africa?
So they were, and they still are, although we're trying to move them. So if you were a contact, high-risk contact, and you weren't protected, the quarantine was 10 days, and then it was moved down to 7 days, testing at 5 days or 6 days. If you were negative, you may be able to go back to work. We ran out of healthcare workers on the front line, essential workers, just like everyone else. But it was essentially 7 days for healthcare workers. Everybody else was 10 days quarantine if you were a contact. And if you had COVID, it was 10 days isolation. So we don't think there's value in quarantine of contacts. There's so much Omicron around, so much of it is undiagnosed and mild. So everybody really is a contact. And especially in essential services, which include health settings, but many others, they were really badly affected because there were so many infections, and it just doesn't make sense. So I think isolation of infected, ill patients, I think that's reasonable. Some countries have done 5. I think we agreed at some stage on 7, but none of that has yet been instituted.
Right. And as
contact tracing, waste of resources, really. I think in countries where, you really just want to mitigate, it really is not worth it.
Right.
We're still doing it, sort of.
Right. In US, as far as isolation guidelines, there have been different, it has differed with time. And there are some places that, recommend rapid tests, a negative test before coming back to work. But during the Omicron surge, we also faced a huge shortage of frontline healthcare workers. I don't know if it was similar in South Africa, that a negative test was required, or that just the 10 days was enough,
It was just 10 days. Remember that PCRs can remain positive for quite some time after infection, and they don't differentiate between viable virus or just persistent RNA. So they do have some limitations. The rapid tests do pick up the most infectious, but you need simple guidelines. I think some of them were so complex. If you this plus that and you do that, and oh my goodness. Simple. No quarantine, no contact tracing, limited isolation for those who are symptomatic and positive, and then send them back to work.
Right, that makes sense. There's a question about, can home test kits reliably detect the Omicron variant?
So I think we don't have them here. I know many countries do. They are variable in their performance, and the quality of the swab is obviously very important. Some barely go into the nostril because it's very uncomfortable. So I think there's the quality of the swab, the quality of the test would be important, but they're less sensitive than PCR. They do play a role. They probably identify the patients with the most virus who are most infectious.
Right.
You get false positives as well. I remember when we did the Olympics, that was a big issue. Nobody wanted to not participate because of a false positive rapid test, and sometimes the PCR was negative. So they're limited, but they do have a role.
Right. There's a question about the abdominal or GI tract involvement in less than 20-year age group. Did you see patients with GI symptoms?
Yeah, I think Wasila actually mentioned that it was much more common in children. So nausea, vomiting, diarrhea, need for fluid replacement, much more common in young children. It was sometimes the reason for the admission. Adults, I think, variable, perhaps less common. Wasila, you must just pitch in if there's something you want to add on any of the answers, please.
Yeah, I was just going to say that the pediatricians reported respiratory symptoms in 43% of cases, GI symptoms in 37%, so quite a high proportion presented with gastro symptoms.
Right, right. There's a question from Mexico, from Dr. Manero. What were the principal actions to stop the transmission of Omicron in South Africa? I think Vassila mentioned some of them, and maybe Dr. Bloomberg, you can just kind of summarize it a little bit.
Yeah, I think masking was very important. So quite early in the pandemic, masking was introduced. Compliance was variable. It was cloth masks for members of the public, because there was a shortage of surgical masks, and we felt those should be made available to health workers. So it was recommended, but it was not regulated formally. And we were one of the first countries outside of Asia to introduce masking. And then it was made, it was a regulation. If you didn't wear a mask in a public space, you could be fined, and people were, I think, pretty compliant. Quite a lot of masks floating below the nose or under the chin, but on the whole, actually pretty good. I think we need to move away from some of that now. I think masking when you're exercising outdoors, I think is not really of any value. But in a closed space, and I think many of our transport means are quite closed, I think they really are very important in reducing transmission. I think trying to do things outside, limiting the number of people in indoor gatherings, limiting funeral attendance, and particularly events post-funerals. I think those were seen as quite important super spreading events. But these lockdowns, I think absolutely shouldn't be continued. I think stopping children going to school has had a major negative effect, as Vassila mentioned. Those are not valuable. And travel bans are absolutely worthless. Right. Travel bans never kept Omicron or any of the other variants out. And they're very, very damaging to the economy. So, you know, I think our socioeconomic effects of some of the restrictions have been pretty horrendous. And I think we really need to think their value. So I think masking, distancing, doing things outside, I think are important. I think for the rest, you need to think very carefully about the negative effects. We need to learn to live with the virus, you know. It's going to be part of us for a while. Vaccinate at-risk people, and let's move forward. Vassila?
Yeah, I wanted to add that despite our levels of restriction in previous waves and the fact that we had no restrictions, so no curfews, no bans on gatherings at all in this wave, it spread and it reached a peak where we saturated the community transmission, and people who are going to get infected got infected, and reached that peak and then turned down. And so it's not the levels of restriction that causes a peak and a downturn necessarily in the waves. That's what we've seen in our four waves.
Right.
I really think we need to focus on vaccinating those who are vulnerable, and a lot of the problems relate not just to the anti-vaxxer movements and the social media problems. There's a lot of vaccine hesitancy, and many of those are people who've got real fears, a lot of questions. We need to address them in a patient-centered, well, they're not patient, people-centered way, at their level, not top-down, and I think address their fears. And you'll find many of them will then understand and will accept the vaccination. I think there are a lot more vaccine hesitant people than this anti-vaxxer group. I would like to think so.
Yeah, I think there's a lot more nuance there, and I think our messaging has not been nuanced enough. So we could do much better at messaging and targeting and making sure that we reach the people who really need to get vaccinated in bigger numbers.
Yeah. Champions on the ground, not top down, you know. That's important.
Do you have any ideas? Because I think this is a major challenge which even US faces is the vaccine hesitancy. And as you rightfully mentioned, Dr. Bloomberg and Dr. Vasila, that it is not the, anti-vax group. It's basically just genuine questions about the vaccines, and it might just be, a knowledge gap, So the question is, how do we spread the reliable messages? And I think the biggest challenge is, even if we do the messaging in a very straightforward, simple way, how do we target it to a larger number of people, who do not believe in vaccines? So I think the target is a major problem which we are facing in US also. Any advice on that, or any experience of how we can target this information so that it reaches, to a larger group of people, who are vaccine hesitant,
Marcella, do you want to go first? You're a very good communicator.
I mean, I've grown a bit despondent because sometimes I feel like we preach to the converted and some of the others just don't want to hear, and they don't want to hear evidence and they don't want to hear stats. I think we need to use a variety of methods. So there is some importance to sharing data, because the data is strong, and for people who are drawn to data, they may respond to that. But I think personal testimonies are important, knowing that my friend or my family member got the vaccine and they were fine, sometimes is more important to someone than hearing a vaccine effectiveness statistic, And I think we need to probably decentralize it. It needs to be coming from church leaders, community leaders, school leaders, people in the community who are trusted and known, rather than billboards or adverts in the paper or TV. But I mean, we haven't gotten it right in South Africa. I'm not sure that we know how to deal with the problem here. And it does seem more and more likely that mandates are, an option to explore, because we need to get people vaccinated quickly. We don't know what the next variant might be like. We know that we might have about 3 months before it hits us. And we need to know that those over 50 and those with comorbidities are vaccinated before then. And so, I believe that the time has come for being a bit stricter and having mandates in place and requiring vaccination for attending events and restaurants and things like that. I think we just must do more with incentives and disincentives.
Right.
So I think all of those, absolutely. I think we can have vaccine champions, people who admire, sportsmen or champions in the community, really getting out there and spreading the positive messages. And then I think addressing specific queries and specific fears. There are obviously some that are quite common, fears about impotency and fertility, even pain of the vaccination, chipping, that you'll have a chip for life. There's some very common questions. And I think we need to address those and make those answers available. Just take a few questions and put them out there. So you'll find many of those are common to what people are wanting to ask, and sometimes are afraid to ask, or go to the internet and get all the wrong answers.
Yeah, and I also wanted to say, it's not simply a question of science versus quacks. Very often people are hearing from other doctors, and they're reading on the internet that a famous virologist or a vaccine expert said this and this and that. So there's a lot of confusion because of what seems like mixed messaging or lack of clarity from the scientific community. And so I think we also maybe need to go some way to clearing that up a little bit and saying, there's scientists and then there's scientists, so to clear up what's real science and what's not. And to also tackle many doctors who are telling people not to get vaccinated, which is a reality here.
Right, absolutely. There's a question about long COVID. What kind of symptoms did you see in patients with long COVID?
We have a study here at the NICD where we're following up patients after COVID-19, both hospitalized and non-hospitalized patients. And we do a telephone call at 1 month, 3 months, 6 months, and 12 months after their COVID diagnosis to look at the rates of long COVID and the risk factors. So interestingly, at 1 month, 89% of people who were hospitalized have persistent symptoms. At 3 months, 69%, and at 6 months, 59%. And so still a vast majority of people, even at 6 months after hospitalization, are still reporting symptoms. Less people report persistent symptoms who are not hospitalized than those who are hospitalized. And the people more likely to have persistent symptoms are older people, females, non-white race in South Africa, people who are in ICU or needed ventilation or oxygen, people with some medical conditions like diabetes, obesity, asthma, and people who had more acute symptoms. So when you had COVID-19, if you had 4 or more symptoms, at the time, you're more likely to have long COVID later. So these are just early findings from our study. It's highly prevalent even at 6 months, and it's very debilitating. People are reporting that they're having to leave their jobs. They struggle with the activities of daily living and social activities. And so I think, yeah, I mean, I think we're so busy dealing with the acute COVID-19 pandemic that we haven't done enough in terms of preparing for people who will suffer with long COVID. Many people just need some reassurance, some information, some guidance in terms of graded exercise and planning their day and sleeping and eating better. But some people do need referral, and we need multidisciplinary services to be able to help them, which includes mental health experts, physio and rehab, physicians. So yeah, I mean, I think that we haven't really started planning for long COVID sufferers and what they may need.
Right.
Yeah, so I think fatigue, depression, and brain fog seem to be the commonest. And
Yes,
then
correct.
sometimes the loss of smell goes on for quite some time. And I think those are the common ones. It's
Yeah.
reassurance, and exactly as you mentioned, just managing it in a sympathetic, supportive way.
Right.
Letting them know it's real. It's not something they're imagining. That this is quite real.
There was a study done at UCSF where I work, that there were actually some CSF abnormalities in long COVID, so as you said, Dr. Bloomberg and Dr. Vassila, is actually real, so there were some CSF alteration causing the brain fog, and memory issues. So it's not just psychological. These are real symptoms. Absolutely. There's a question about school reopenings, as you mentioned, it's detrimental to the education of students if the schools close. How can what protection measures can be taken to make sure that the children are safe in the schools during the COVID-19 surges?
I think number one is to ensure the teachers are vaccinated. Many have comorbidities. We've certainly lost a number of educators. And I think it's to ensure that they are protected. I think well-ventilated classrooms are important. I think that's quite difficult. What they did was to limit the number of children in school and alternate the days. But that's had a major effect on education. And I think we need to move away from that now. And this continual opening and closing of schools and quarantining of contacts of one in a class, I think with Omicron and going forward, I think that needs to stop. I think we need to vaccinate those who are vulnerable and particularly protect the teachers. And, I think the value of education, for us, it's a safe place for most children. It's a place where they can get fed and educated. Many cannot work online or be taught online. I think we're going to see the damage from this for many, many years to come. Priscilla, do you want to add to that?
Yeah, just to say that, we know the measures that we can take, and I think our schools have been quite good about implementing, distancing and mask wearing. But the reality in South Africa is in many settings, there are 50 to 60 children in one class. how do you distance? How do people isolate in shacks where 6, 7, 8 people are in a room? So the context in South Africa makes it very difficult to follow and adhere to some of these guidelines, which would be ideal. But I mean, I still believe that kids are not at risk for severe disease. I think that wearing masks is a good measure. But I think that there's more detriment to closing schools and keeping kids away from school. We have had outbreaks, in schools during the waves, and that's a reality. But more often kids have transmission at homes and in their own communities, and not at school, is what we found. But I mean, I think we can only try to have better mask wearing and ensure that we diligent about that. But I don't think we can close schools, and I don't think we can do much better with distancing with the context that we have here. We can't ask kids to come on alternate days and to have reduced numbers in classes. We just have to go back to schools properly now.
Right. I have a daughter, so I completely agree with you about the schools. Now, as you know, I think South Africa did an excellent job in picking up the Omicron variant so fast, so early, and also sharing the data with the world. Do you have any advice for other countries for detection of variants in a very fast and prompt manner, so that they can be detected early and they can also help the world with sharing the data as South Africa did?
I think it's very important to have a program, a laboratory program, alongside your diagnostic program for sequencing. And within that sequencing program to do good surveillance. So you could do it in response to increases, but I think it should be done as a continual program. Don't wait for the outbreaks. Start to identify some changes and then just align them with the epidemiology and what's happening. So, I think genosequencing, molecular sequencing is very much part of outbreak response now and outbreak prediction. And I think it needs to become a lot more routine. I think resources, are a lot more readily available. It's a lot cheaper than it used to be. And I think, we need to make sure that all countries have the ability to do this. And I think there's a big move now to make gene sequencing or sequencing of viruses, other bacteria, very much more mainstream than it used to be. And I'm involved in that at WHO level. So we have an excellent academic institutional partnership program in South Africa that I think has really been pushed along through COVID, where they work together in many different institutions. There's a weekly meeting to discuss findings, and it's not reactive, it's really proactive, and it's a surveillance program. It's very, very critical. Vasily, you wanted to add something?
I wanted to add that South Africa is not a high-income country. We did not have any hospital surveillance systems running before the pandemic, and we set up this COVID-19 surveillance system at the very early part of the pandemic in March 2020, and got all public and private hospitals to respond, to report just on minimal data fields on the COVID-19 admissions. And so why I'm saying that is because, it is possible, even in lower resource settings, to set up a fit for purpose surveillance system. It may not be high end, and it may not have all the data that, people in upper income countries can report on, but it was sufficient to be able to monitor the trends in COVID-19 hospitalizations and severity and mortality. And I think similarly with our sequencing, we have a network of genomic surveillance here, sequencing in South Africa. So there's a few institutes around the country. We don't sequence all the infections. We do a couple of thousand every month, but that's enough for us to monitor and pick up and identify new variants that need to be watched or need to be reported. So, the point of my response is that there can be a solution that's fit for purpose, even in lower resource settings. But that surveillance is absolutely crucial and key.
Perfect. That's great. Actually, and as you mentioned, majority of our audience is in low and middle income countries. So these are really good, important points which you have discussed for the surveillance program, which are really helpful. As for a question about the Omicron subvariant, what are you seeing till now, and what is your experience with it in South Africa?
Go on, Vassila.
We are picking up the subclades, and I think the BA.2 is about 20% of all sequences in January. So we don't yet have any data on any differences between them, but we continue to watch them.
Right. I think it's kind of early, as you mentioned. All right. I think we should stop right here. We are getting close to 8 a.m. here in California, but thank you so much, Dr. Bloomberg and Dr. Vassila Jasset, for this excellent session. The slides were great, and the question and answer session was so informative for our audience. There are a lot of thank yous and excellent presentations in the comments and the Q&A on both Zoom and YouTube. So I really appreciate this, that you did this for us. Thank you so much. And I hope you have a wonderful evening in South Africa. Thank you so much.
Thank you, everyone.
Thank you very much.
Thank you. Have a good evening. Take care. Thanks everyone for joining. Take care. Bye-bye.